talk is called Proton Beam Therapy for Brain Tumors in Children and Adults. And today's agenda will see a discussion firstly on the proton beam therapy for children, proton beam therapy for adults, and then we will do a compare and contrast. Some of you may know that we have had the privilege of Dr. Daniel Kwa sharing with us about Boron Neutron Capture Therapy and conventional radiotherapy in earlier sessions last year. And we'd like to know what the differences or the similarities are. So I have already invited Q&A at all times, and you will capture it on the chat. And at the same time, do expect that there will be polls that I have created to engage you and to hear your voice. So who do we have with us today? Well, our presenters are all BTSS Medical Advisors. And this is a special arrangement that we have made with the National Cancer Center for this talk. As you all know, we are anticipating the building of the facilities for proton beam therapy. And we had hoped for it to be up next year. But let's see what our doctors have to say about this. But even before we quickly book an appointment for ourselves, we better find out what this new technology is about. So Dr. Wong Wu-Sin, she's a specialist in proton beam therapy, practicing overseas in a very prestigious institute. And Dr. Daniel Kwa, who knows a lot about boron neutron capture therapy, and Dr. Kevin Chua, who is an experienced radiation oncologist. All three of them would be sharing with us today. And Dr. Wong will give you a more detailed introduction later on. Okay, so with that, right, I am going to invite Dr. Wong Wu-Sin. You can start the presentation, please.
Yeah, hi. Just give me a moment now. I'll start presentation mode. Okay. Right, yeah. Thanks, Melissa, for the introduction. Okay, and also, David is a neurosurgeon. He invited me to give a talk, so I'll just take about 15 minutes and I'll try to be very simple and straightforward. So I have some disclosures. I received some proton therapy training overseas, but I'm still waiting the commencement of our own local machines. And I subspecialize only in breast cancer, pediatric, and sarcomas, not in adult brain cancers. But fortunately, I have my colleagues here with me, Dr. Kevin Chua. He is a radiosurgeon, and Dr. Daniel Kwa, who is a boron neutron capture therapy advocate. So just to start very, very simply, what is X-ray, what is proton, and the indications of proton in children and adults? So X-ray. How X-rays work is that it causes free radicals in cancer cells, and these free radicals causes DNA damage. And this DNA damage then causes the cells to die off. It is believed that normal cells are more capable of self-repair compared to cancer cells. So what is a proton? A proton is a particle, and physicists believe that it's made up of 3 quarks. Proton has a mass and it has a charge. And what is a photon, also known as X-ray? An X-ray is a waveform, it's massless and it's chargeless, and it's along the same spectrum as visible light. So X-ray radiotherapy has a very long...
Wu-Sin, I'd like to request that you go a little bit slower because there's a lot of interesting information. And yeah, we would all like to keep up.
Yeah, apologies for that. Okay. So I will go slower. So what is X-ray therapy? X-ray therapy has a very long track record in the treatment of cancers. Nowadays, it is also very advanced. There are options like VMAT, which stands for volumetric modulated arc therapy or radiosurgery. You can see here for radiosurgery, essentially it's many, many beams focusing on a very targeted area. And for arc therapy, X-rays go around the tumor in many, many arcs, creating a very conformal treatment. So what are the advantages of protons? Right, the main advantage of proton lies in its physical nature. Because the proton is heavier, And once it's deposited in the patient's body, it causes very little penetration. It stops, and then that's very little distal dose. So this is the main advantage of protons. How about disadvantages? Right. Firstly, it's incrementally a lot more expensive, and accessibility is an issue currently. And because of its physical nature, there are many uncertainties compared to using X-rays. For example, because it is a particle, sometimes physicists don't really know how to predict its interaction with water, with air, and also with motion when the patient is moving. For example, this is a lung tumor planned on X-rays and the same tumor planned with protons. If the patient breathes and moves a little bit more forward, you can see that the tumor may be underdosed. And if the patient moves a little bit to the left, the esophagus, the critical structure, may be in the hot radiotherapy zone. And that is a bit dangerous. So exponentially, there are more and more proton facilities being built worldwide. We may think that proton therapy is a new technology, but actually it was started in the 1950s in the United States. But due to engineering and technological limitations, the treatment was then given via a technique known as scattering. So what is scattering? Essentially, imagine paint being splashed around a template or mold, okay? And nowadays with very, very strong magnets, all right? These magnets are used to deflect the protons, to paint over the tumor. So the analogy would be a pencil being drawn over the tumor. So this is an artist's sketch of the new NCC West building. We have procured the Hitachi machine, and it's a huge mammoth undertaking. So this is the floor plan. You can see the accelerator here, and we are expected to have 4 gantries, and we will be mostly subterranean at basement 3. This is the original building timeline. And of course, administrative preparation started way before. So there will be some delays, unfortunately, largely because of the ongoing pandemic. Okay, so just to illustrate the mammoth undertaking, this is the hardware, the infrastructure for just 1 gantry. Each hardware is 220 ton for 1 gantry, and it takes up a lot of floor space, 9.4 meters lengthwise and 5 meters height-wise. When I was in St. Jude, this is the accelerator and the huge magnets to deflect proton particles. Okay, quickly moving on to pediatric brain conditions. I believe proton will be beneficial in conditions like medulloblastoma, germ cell tumors, ependymomas, low-grade gliomas, craniopharyngiomas. Essentially, any pediatric indication with an expected reasonable chance of long-term survival would likely benefit. Whereas, unfortunately, patients with high-grade tumors that are more aggressive, they may not benefit from proton therapy. So medulloblastoma is a very aggressive tumor that happens in young children. Fortunately, it's also a poster child for proton therapy because the whole neural axis needs to be treated. So the brain and the whole spine. It's believed that there's a high potential for tumor seeding. Okay, and with protons, this is the proton plan, and this is the corresponding plan with photons, with X-rays. You can see that there could be more sparing of the hippocampus, which is the part of the brain responsible for like IQ and memory, and also a lot less doses to the anterior, thoracic and abdominal organs like the heart, the visceral, the bladder. And hopefully the risk of second cancers in long-term survivors are decreased with proton therapy. So in a very, very quick summary, proton therapy can help kids by decreasing dose to normal tissues, hence minimizing long-term side effects and mitigating chances of secondary cancers. Okay, quickly moving on to brain tumors. I think the benefit of proton is less clear-cut and more debatable. For example, for base of skull tumors, I think the benefit is there. Maybe there's some benefit for patients with larger low-grade meningioma, pituitary adenomas, low-grade gliomas. I underline larger because larger tumors require more treatment, more surface area to be treated. And with protons, it's more likely to spare more normal tissue. However, proton is likely not going to be beneficial in indications with poor prognosis, for example, high-grade gliomas or brain metastasis. And for very, very benign and small lesions that can be very safely treated with existing technology, like vestibular schwannomas, they're also not likely to benefit very much from proton therapy. Okay, base of skull tumors would be a poster child in adults. Okay, you can see here, there's a tumor here, and it's situated in a very, very critical region with your optic nerves and your brainstem. Okay, so the prognosis is actually very good if a high enough dose of radiation can be given. And to give it safely is a lot better to give with protons compared to X-rays. Okay, for low-grade gliomas, it runs a spectrum, and some patients can survive a long time, and there may be benefit if we can spare the nearby normal tissues. This is with X-rays, and the inferior diagram is with protons. How about high-grade gliomas? Unfortunately, medical science hasn't really caught up, and outcomes are still very guarded. Trials have also shown that increase of dose within the tumor are not effective. So the standard of care currently would be chemo and just X-ray radiotherapy. However, there are some small ongoing trials to find out if proton can improve quality of life during that 1 or 2 years, all right, and can mitigate the cognitive impairment of radiotherapy. However, I do not expect the benefit to be very marked, probably more modest benefit, if any. Okay, moving on to brain metastases. Very commonly, brain mets are from extracranial tumors, for example, breast or lung cancers. And the prognosis is usually quite grave, although there can be outliers who can have long-term control, and they can be treated with either conventional surgery or radiosurgery. And vestibular schwannoma is a benign tumor. If large, the patient will require surgery with or without adjuvant radiotherapy. And even with conventional X-ray or radiosurgery alone, the outcomes are very good, toxicities are very low. Okay, so some people may ask, why not give proton radiosurgery? However, protons are associated with a lot of physical uncertainties, and the very nature of radiosurgery requires very few fractions of very, very high doses, and hence it's very unforgiving, all right? And with protons, you know, with certain physical uncertainties, sometimes it may be dangerous to give radiosurgery with protons. Not that it cannot be given, but a lot more considerations have to be given. Okay, so in a very simple nutshell, proton therapy is of greatest benefit in younger patients with a good prognosis because of normal organ sparing, and in certain indications, proton therapy can deposit more dose into a tumor that is classically more radio-resistant, for example, in base of skull chordomas. However, in adults, the benefit of proton therapy is more debatable. Okay, with that, I'm happy to take questions or hand over to my colleagues.
Okay, Lucy. I'm checking the chat and I noticed that there are no questions at the moment. So to facilitate the questions, I actually have created a poll. So everyone, get ready for the poll. I'm going to launch the poll right now. And I'd like you to log in your answers by clicking any box that applies to you. So we're going to talk about concerns, your biggest concerns for proton beam therapy are costs, access to the proton beam therapy in Singapore, about safety, about side effects, the experience of doctors, the medication required alongside proton beam therapy, the lack of information as new in SG, Singapore, and others. So please lock in your responses right now. So far, 5 people have responded. Come on, we can get to 10. 6 have responded. All right. Meanwhile, there is a question, Hussein. The question is, are there any differences between the existing proton beam machines, example, Taiwan and Korea?
Yeah, good question. So, from what I know, Taiwan and Korea both have proton centers. There are a few in Korea actually. There's one in Seoul that I refer to, and they both have advanced technologies. What I presented before, IMPT using the pencil. And for the second part of the question, what's the cut-off age for children?
Yes.
There's no real cutoff, although generally in patients younger than 1, we try not to give any radiotherapy, even protons, right? If certain conditions can be controlled with chemo, we'll give chemo first. When patients above 1 and really needs radiation therapy, 1-year-old would be an arbitrary cutoff.
Right. Okay. Does that answer your question, Karen? Right. So meanwhile, while waiting for more questions, I'm going to show the polling results, okay? And perhaps that could be a point of discussion. So I'm sharing the polling results right now, and it seems as if, like, for most who are attending, the biggest concern is really the cost. You know, perhaps the doctors would be able to give an indication of the cost that needs to be set aside for proton beam, whether or not we can expect subsidy. The next, as you can see, the orange bar shows that is the biggest. Okay, the next one looks to be like at the 50% is side effects. So perhaps we could discuss the side effects as well. And then the third concern would be a tie between safety, okay, and also the lack of information because it's new, right? So perhaps let's spend about 5 minutes talking about this.
Yeah, these are very good and valid concerns. So, cost, I've been told by the lead director of the Proton service that talks have been underway with MOH to try to make costs more affordable. And certainly there'll be subsidies for indications that will benefit from proton therapy, for example, base of skull tumors, in pediatric brain tumors, and certain adult tumors. And patients can expect subsidies. Patients can expect to use their Medifund, their MediSave, and insurance companies, a few of them have come out to say that, you know, if it is indicated, they will cover. So I hope this answer can reassure our participants.
Okay, right. Yeah. So cost was one. I think let's talk about side effects. Feel free, Kevin and Daniel, if you'd like to add your inputs. So what are some possible side effects? Although it minimizes a lot of effects from the conventional therapy, but what are still possible side effects?
Kevin?
Right, so perhaps I can go first. Can everyone?
Yes, we're good.
So, to put simply, we don't expect there to be very significant differences in terms of, okay, so perhaps the easiest way to answer this question would be that proton and photon radiotherapy are not that dissimilar. So it really comes down to a function of dose. Because proton delivers the radiation in a different manner, and therefore we tend to expect a reduction in the moderate and perhaps low doses that spill over into the surrounding normal tissue. To to put it simply, essentially, when we have a target, that target needs to be given a certain amount of dose to achieve a certain intent and to achieve a certain tumor cell kill. So that dose is determined more clinically and biologically, and that doesn't change. So if you have normal tissue that is in the immediate vicinity of that target, because it's still required to receive a certain dose, so that doesn't change. So in terms of the side effects that you attribute to high radiation doses in that target or in the immediate vicinity of the target, then that's not very different. However, with protons, what we do see is a dosimetry advantage in normal tissue that's further away. So traditionally, with conventional radiotherapies, this tissue that's further away would tend to receive low doses, moderate low doses, and I think certainly in the pediatric patient population, we are very even such low doses make us essentially a little bit concerned, because we don't know what the impact on future development will be. And as Rusin alluded to, for adult tumors, then selectively, for patients that we think are going to do very well, and essentially, we start worrying about some of these long-term late effects, then potentially that's where proton will come in very useful. Yeah, I hope that answers the question. Yeah, Daniel, do you have anything to add?
No, I think Kevin is spot on. Is everything all comes down to when you talk about side effects in radiotherapy, is a function of not just the organs being treated, but also how long the patient has survival from the point of radiotherapy. And yep, so for patients with prognosis which is not so long, right, where they will not unlikely to experience late toxicity or late side effects, then proton therapy may not have such a distinct advantage.
I hope this answered the questions. However, if you have further questions, you can just put it in the chat, Karen. Now, the next question is, in a doctor's opinion, is surgery better or proton beam better for the patient, or a combination of both? Who would like to take this? All right, David. Can you unmute? Yes.
Hi, Melissa. Hi, everyone. Yeah, so I think the general principle has always been in management of any patient with a brain tumor that the surgery should be done first to remove as much of the tumor as safely as possible. So this could happen in one go, or sometimes surgeons may even stage the procedure in order to remove as much of it safely. Failing which, whatever tumor is left, depending on the type of the tumor, then we'll decide what is the next step of treatment. So if it's a malignant tumor, classically radiotherapy and chemotherapy will be the following treatment. Hence, in short, basically surgery first, then the subsequent treatments. If the tumor is benign, and in certain types of tumors, they may not even be very sensitive to radiation treatment. Hence, that may not be something that would even be considered.
Right. So we are just hearing that, there is no standard answer that will satisfy all medical conditions, because we hear from the doctors that it pretty much depends on, the stage of the type of the tumor that you're talking about, whether or not it will be responsive to the proton beam. And if it's a sizable one, you may need to combine it with surgery as well, right? But we do hear that, the immediate tissue area around the area where it receives proton beam, it may have the same kind of side effects, but the tissue that's further removed away from the tumors would tend to be better safeguarded under proton beam therapy. Right. So I'm going to just ask one question before I ask Daniel to make a comparison with boron neutron capture therapy. And that question is proton beam therapy recommended for DNET tumors that's not removable but via surgical means? So I think maybe, yeah, any one of you can just raise your hands if you want to take this question.
Can I just verify that it's PNET, PNET?
Yes, I'm not very sure because DNET sounds like something on the internet, for me. Yes, Jing Yuan, can you confirm? Are you talking about PNET? Maybe, Lucina, want to proceed. Let's proceed to answer based on PNET because it makes the most sense to us, right?
Yeah,
Yes.
even with PNET, historically, certain tumors were known as PNET, but however, this term is no longer applicable. People prefer more specific terms, for example, medulloblastoma, germ cell tumors, and the specific subtypes. So if it's a germ cell tumor, sometimes surgery is not really needed, just for biopsies only. And germ cell tumor is a type of tumor that happens in very, very small children that has an agent predilection. But if it's a PNET known as medulloblastoma, then David's role is a lot more significant. The surgeons will need to remove, and then we follow up with radiation to the whole craniospinal axis.
Okay.
Yeah.
He
So
has just
to
clarified.
yeah.
Yes, if you look at the chat, he's just clarified. Yeah, doctors, you want to look at
Yeah,
the
I was just gonna add.
yeah.
Sorry, Melissa. That for DNETs is a WHO grade 1 tumor. So it is a benign tumor, and usually surgery is able to remove most of them because they typically occur in certain locations which are reasonable for surgical excision. Of course, rarely there may be portions of the tumor that are very deep seated in the brain, and the surgeon may have to leave some behind. So I don't believe the standard of care would be for radiation treatment. Usually they may be observed with follow-up scans. The great concern for the DNET tumors is that over a long period of time, it has been reported that they can become, they can undergo change and become aggressive tumors. So they need regular follow-up.
So, Jing Yuan, thank you for your clarification. So, Dr. Low has responded that generally the preferred option is surgery, but close monitoring because there is a chance that it might evolve into a more aggressive form of a tumor. Okay. Thank you for answering all these questions. And let's move on to a compare and contrast. All right. And Daniel, it would be over to you to share.
Okay, can everybody hear me? All right.
Yes.
Okay, so yep. So I'm here today to try to compare and contrast boron neutron capture therapy together with what Ru Singh has described, as well as conventional photon therapy. So now to add on to all the discussion we've just had, right, from what Ru Singh had said, as well as the poll that we had, right, we must all understand that the reason why we are always seeking newer radiotherapy techniques is because of this concept in radiotherapy, which is we are always trying to push as high a dose as possible to the tumor, but as low a dose as possible to the normal structures. So this is always the everything what you're doing, which is why Proton we try to push as high as we can there. So, but like Ru Singh said, right, Proton currently is shown to be of greater benefits in the younger population with a good prognosis. So then, does it mean that the question then follows is that what do we do for patients who do not fall into that criteria? How can we try to push the dose, push the envelope for this group of patients? So which is why we talk about BNCT today. So BNCT or Boron Neutron Capture Therapy is something that I've been interested in for almost 3 decades really. And okay, so basically it stands for BNCT here. So basically the idea behind BNCT is this reaction. So what happens is that neutrons, when they combine with boron, right, it creates a local reaction that produces these 2 particles, the alpha particle as well as the lithium-7 ion. These 2 particles are highly energized, highly destructive particles. But the good thing is that they are short range. Their range is only around a cell long, the diameter of a cell. So the idea behind BNCT is this. Right? First, boron is injected into the patient, and then it is accumulated within the cancer cell. As you can see here, all these normal tissues, normal cells, oops, sorry. Right. All these normal cells, right, in which boron is not concentrated inside them. Then a neutron source is then irradiated to the region. Now, you can see that in the cancer cell, the neutron will be captured by the boron, whereas in the normal tissue, neutron beams will just pass through harmlessly. So within the cancer cell itself, the BNCT reaction will occur. So literally what happened is that once the neutron is captured by the boron, it splits into the 2 particles, which then kills the cancer cell. So to summarize, right, basically what happens is this. This is the before, right, where the tumor cells containing borons here, and then neutrons irradiate. And after that, because the cancer cells are being destroyed, right, what we have left is mainly the tumors who have not taken out boron, which are the normal tissue. So these are some pictures to illustrate, right, the efficacy of BNCT in glioblastomas. You can see that you can see effects even within 48 hours, and by 5 weeks, disease have just virtually partially responds a lot. Right? And studies have compared BNCT with conventional treatment for glioblastomas, and you can see that when you look at this slide, it's talking about survival. The BNCT group survival is actually quite good compared to that of the conventional treatment of radiotherapy plus chemotherapy. And likewise, when you look at further down, the 2-year survival, the 3-year survival, as well as the 5-year survival, right? The outcomes are actually comparable, if not better, than BNCT. Than conventional therapy, sorry. So, the other way to look at the advantage of BNCT compared to conventional therapy is through this diagram. So, conventionally, the current treatment for glioblastoma is surgery plus post-op chemo RT. And we're talking about 6 weeks of chemo RT followed by 6 months of chemo. And then, whereas for BNCT, you're only talking about 1 day of BNCT. So the amount of time that the patient gains then from not having to go for any treatment is then much longer in terms when it comes to BNCT compared to the chemotherapy side. So I mean, I'm speaking from as this more in this slide as more of a supportive care, palliative care physician, in that sometimes we have to actually look at what we are taking away from patients whenever we give them treatment. So now, I think this slide will kind of illustrate what we've all been talking about just now, right? So comparing all 3 of them, the X-rays, which is the photons, the protons, which is the blue, the green line, and BNCT. Now, so let me try to explain this picture. So this axis here, right, talks about the depth. So at 0, this is the skin. So the beams, right, be it BNCT, X-ray, or proton, are coming from the left to the right of the screen. Right. As you can see for the X-rays, right, X-ray beams will go in first, and then they'll actually, between the skin to the tumor, right, a lot of the normal tissues will get the radiation before it reaches the cancer. And then after that, there'll be still X-rays leaving to the tissues deep to the cancer. Whereas in contrast, proton, right, has a green line here, right? When it enters after it enters the skin, the amount of radiation deposited in the normal tissue is much lower compared to that of the X-rays. And then after the cancer, it just drops all the way down to this point. Okay. So, but then when you then look one step ahead and look at BNCT, right? Because we are looking at because the reaction only occurs in cells which accumulates boron itself, which is the cancer cell. We are expecting this sort of diagram, this sort of curve, whereby the dose deposited in the normal tissue is significantly much lower. So this goes back to my first slide, which is everything we do in radiation oncology is about trying to give the high dose to the cancer with as low dose as possible to a normal structure. Right. So how is BNCT progressing over the world is this, right? You know, it's actually something that's not very well heard of. Back 10 years ago, right, when I was at a conference, all those machines that produces neutrons for BNCT were all mainly in the theoretical phase. But then 4 years later, Japan already built 8 of them. And last October, when I attended a conference, right, there are already 20 of them being built in various stages. So this is an expanding field. Right. So I think with that, I hope it gives everybody an idea of what it is. And with the preceding slide, shows everybody how we compare and contrast all three radiation treatment modalities. Thank you.
Okay, thank you, Daniel, for sharing this. Okay, now I'd like questions to come in, please, for the compare and contrast segment with proton beam therapy.
Sorry, if I may ask Daniel.
Yes.
And
Yeah.
what's the cost of
Rosin, would you want to show yourself on the video? Yeah.
Sure.
Yeah.
What's the cost of BNCT compared to, say, if proton was available in Singapore for the patient?
So currently, currently the most BNCT are performed in nuclear reactors. So the cost of having a treatment in BNCT now will have to pay for rental of the nuclear reactor. So currently, Taiwan is charging an equivalent of around 40,000 USD for one course of BNCT. Yeah.
So compared to, like, say, proton in Taiwan, actually BNCT will be comparable?
I'm not sure how much are they being charged for proton there, but it'll be quite an interesting thing because a few years down the road, I know one of the centers in Taiwan the Changken is acquiring a BNCT machine themselves. So it'll be quite nice to see them how they price their treatment accordingly then.
Okay. Yeah. I think, perhaps it's a good place whilst we're also talking about cost too, because I think many patients tend to be very excited when they hear about BNCT, because it seems like you just go for one time and you kind of like experience a very efficient outcome, So perhaps it's good to recap again. What sort of brain tumors would be most suitable for boron neutron capture therapy treatments?
Okay, so currently now for BNCT, in fact, any treatment, any tumor type that we want to use BNCT for, one of the prerequisites is that as long as it can take up boron, right, then it's suitable. So most of the time we are looking at the more aggressive tumors, right, and those are the ones through studies which been shown to be having a higher propensity to uptake boron.
Right.
So
So
things like GBM and malignant meningiomas.
the GBM, yes, because from what I know, most of the time all the earlier boron BNCT treatments have been in respect of GBMs. So apart from GBMs, has it been treated for other forms of brain cancer, such as, like for example, the kids, the medulloblastoma and the astrocytomas, for example?
Okay, so for medulloblastomas, there have been reports of it being used in the treatment of recurrent medulloblastoma, not so much as the first line. And likewise for astrocytomas, also in the recurrent setting. So think of currently, because BNCT is still rather new, it is usually used for patients who have exhausted all standard treatment.
Okay, understand. Yeah, and there's a question, from Jun Fong asking, how do you ensure that the boron is attached to the cancer cells and not the normal healthy cells?
Right. So, good question. Good, tough questions. Okay. Currently, the agent that we use to send the boron into the cancer cell is this compound called boronophenylalanine. So it's an amino acid, and what happens is that it has been studied that cancer cells usually have this increased affinity to suck in this this phenylalanine, and so we make use of this property to show that there's increased dose of boron inside the cell. Now, prior to actually patients undergoing for BNCT, they have to go for a special type of PET scan to show that the tumor itself has taken up adequate amount of boron. Right. So is as long as the ratio between the normal tissue as well as the cancer cell has a significant gap in terms of boron, right? Then the treatment will go ahead.
Okay, and there's also a further question about the efficacy of BNCT in recurrent GBM. Any difference between the treatment efficacy on initial diagnosis versus recurrent disease?
Okay, put it this way. There was a study that, just now when I showed, right, the study that compared BNCT and standard treatment for GBM for newly diagnosed patients, the efficacy is similar, right? When we talk about survival, all these things almost similar. So it boils down to how much what I call treatment-free time is obtained with the BNCT, and the recurrent setting. There's no real, correct me if I'm wrong, Kevin, but there's no real standard treatment way of treating recurrent GBM. Right. So it's still I'm still trying to collect data to see how this compares with the general literature, but so far it seems equivalent, if not somewhat better.
All right. And how can a patient who is interested in BNCT gain access into consultations for BNCT while in Singapore?
I'm happy to see them and to talk to them about it.